Hi, I'm Charlene Archuleta, and today I'm presenting the case of an individual with type 2 diabetes and depression. I found the interplay between these two chronic diseases to be interesting. BC, a 32-year-old Hispanic female, presented to the office for a routine diabetes check. She'd been diagnosed with type 2 diabetes approximately 12 years prior, in her early 20s. Her most recent office visit had been 6 months prior. At that time, her A1C value was elevated at 8.9%, and her primary care provider had adjusted for insulin and recommended a 2-week follow-up. Unfortunately, she had no-showed for 3 scheduled follow-up appointments. Review of her medical records demonstrated historically poor glycemic control, with her A1C value hovering at around 8%, and trending upwards. For active diabetes, medications included metformin, NPH, and regular insulin. On the date of service, she reported stopping all medications over the previous 3 weeks, having difficulty. She reported having adequate medication supply at home, but was having difficulty remembering to take her medication and difficulty performing self-care activities, symptoms which she attributed to depression. She had been diagnosed with depression approximately 2 years prior, and although she reported having recalled symptoms as early as her teenage years, she reported that she never reached a point of remission, but there had quote-unquote been times that were better than others. Prior to discontinuing her medication, she had been taking sertraline at a dose of 200 milligrams daily, which is the maximum daily dose. And she described her psychological state as not good and expressed problems related to her education, finances, occupation, and social support system. A review of symptoms was positive for fatigue, difficulty sleeping, headache, bilateral foot tingling, generalized body pain, polyuria, dyspnea, and polyphagia. In addition to depression and diabetes, her past medical history was also significant for hypothyroidism, tobacco abuse, hypertension, and obesity. Her surgical history included 2 prior C-sections, the first of which was for an LGA infant. Her family history was significant for type 2 diabetes in both parents, depression and hypertension on her mother's side. On physical exam, she was an obese female with a BMI of 36. Her blood pressure was elevated at 144/90. Her lower extremity exam was abnormal, with decreased sensation bilaterally up through her ankle area. She was in no apparent distress and relayed her history without difficulty, although she was teary at times, particularly when relaying her psychosocial history. Her cardiovascular, pulmonary, neurological, and integumentary systems were all within normal parameters, and her point of care A1C was 9.5%. Her PHQ-9 score was 15, which is consistent with moderate to severe depression. So basically, her A1C value of 9.5% reflected an upward trend, which was concerning. Her history of physical and lab findings were reflective of micro and macrovascular changes related to poorly controlled type 2 diabetes. Specifically, her prior labs reflected microalbuminuria, while her review of symptoms complaints of lower extremity pain and physical exam findings of decreased sensation were consistent with diabetic peripheral neuropathy. Her elevated blood pressure reflected large vessel rigidity, and obesity and tobacco abuse were diagnoses further elevating her risk for coronary heart disease. There was a high clinical suspicion that her complaints of fatigue and difficulty sleeping were largely due to the depressive episode, with hypothyroidism as a likely contributor to the fatigue. Multiple etiologies were suspected as contributors to her complaints of gradual onset headache that began shortly after discontinuing her medication, including hyperglycemia, SSRI discontinuation syndrome, and or possible tension-related headache. Her PHQ-9 score of 15 was consistent with moderate to severe depression, so overall her depressive symptoms were the primary source underlying her treatment non-adherence and the resultant chronic disease complications. So the comprehensive plan for BC was to refer her to a mental health professional. She was restarted on sertraline at a dose of 50 milligrams daily, with a plan to increase her daily dose at weekly intervals until the maximum dose of 200 milligrams per day was reached. The plan was to consider augmenting treatment with bupropion versus switching to an alternate antidepressant, depending upon the patient's response to the full dose of sertraline. This was to be determined after an 8-week trial. For type 2 diabetes, we drew some routine labs, including fasting lipids and another urine microalbumin. Her medication, metformin, she was to increase her daily dose from 500 to 1,000 milligrams twice daily, and she was to resume her insulin and begin checking her fasting and before meal blood sugars. She was to return to the clinic in 2 weeks to meet with the diabetes educator and with the goal of titrating her insulin up. In treating her and creating her treatment plan, I began to wonder if there was a treatment for depression that would have a dual impact on her diabetes outcomes. Was there a depression medication that might also help lower her A1C value? So I found an article, a systematic review that was published in 2001 by Markowitz and colleagues, and basically they explore the impact of medication, psychotherapy, and collaborative care interventions on hemoglobin A1C values. And what they found is that the tricyclics, specifically nortriptyline, led to worsening hemoglobin A1C values, so that would have been a very poor choice for her depression treatment. But the SSRI, specifically fluoxetine and sertraline, produced results that were consistent with improved glucose levels by up to 1 point. And bupropion also showed favorable outcomes on hemoglobin A1C values, also on BMI, body fat, and for patients who were experiencing adverse sexual side effects. So bupropion was demonstrated to be a really good treatment for depression in type 2 diabetic patients. With regards to psychosocial intervention, they indicated that there was some research to support CBT. Some patients receiving CBT demonstrated reduced A1C values close to a point as well. So both the SSRIs and CBT demonstrated favorable reductions in hemoglobin A1C values. Collaborative care, which was defined as a stepped approach, which is commonly utilized in primary care, was found to be a cost-effective way to improve depression. However, it did not appear to confer benefits on hemoglobin A1C value, which was surprising. Some of the limitations of the study included that only 17 studies were included in the review, 3 of which were published within the past 5 years. The individual studies were smaller in size, with 13 of the 17 studies being less than 150 patients. And the study results suggest, so basically the study results suggest that certain antidepressant medication and cognitive-based therapy may have favorable impact on blood glucose levels. I was surprised to read that the collaborative care group, which incorporates both elements of psychotherapy and medication, did not have an impact on blood glucose levels. The authors did suggest that this may be due in part to less intensive psychotherapy interventions in the collaborative care group as compared to the psychotherapy-only group. These results suggest that intensive cognitive-based therapy and bupropion could provide the dual benefit of improved depression and diabetes measures. So specifically for BC's case, bupropion would have been a great medication to augment if she doesn't receive a full response to the SSRI because of the reduction in BMI, because of the favorable benefits on tobacco abuse cessation, and the depression and the diabetes for reduced A1C values. For my therapist, I used Jean Watson. In both my assessment of BC and the clinical inquiry, they were both driven by the underlying belief that the mind and the body are connected. So the assessment that BC's depressive symptoms or the mind were the primary barrier to her physical health, or diabetes, hypothyroid, or hypertension management, suggests this mind-body connection. Furthermore, my clinical inquiry as to whether treating depression would improve diabetes also assumes this mind-body connection. The interconnectedness of the mind, body, and spirit is a central tenet for Dr. Watson.